This is Robert, sleeping deeply on his first day of life on our planet. Resting beside him is Angelique, his mom. Angelique is 20 and lives with her mother in a two-bedroom apartment in the North Bronx. Robert is her second child. Her first is now 3. She didn't finish high school but is well on her way to taking the GED and dreams of opening a tattoo parlor with her boyfriend. For now, she works part-time at the drugstore, picking up extra shifts when she can. She is resting and recuperating after the tireless work of being a young working mother, contemplating the impact this child will have on many aspects of her life as she navigates income insecurity, housing limitations, her strained relationships with her mom, and whether they'll hold her part-time job when she returns. I listened to Angelique's story as I took care of her as one of her midwives. Her story is one mixed with possibilities and vulnerabilities. Angelique's story is not unique for many vulnerable women in the city, and it is women like her that are cared for by a midwifery workforce that is employed by the vast public healthcare network scattered throughout the boroughs. These women face significant challenges in many parts of their life and happen to be the population most at risk for poor maternal health outcomes. Being a young, poor woman of color increases your risk of becoming ill during the otherwise healthy event of pregnancy and birth. In New York City, black women are 12 times more likely to die in childbirth compared to their white counterparts. 12 times. What is more striking is that despite our astronomical spending on childbirth, the highest of any other country, we still rank 61 out of 180 countries on maternal health outcomes, putting us on par with Afghanistan and South Sudan. There are many factors that create and perpetuate maternal health disparities, factors that are marked by inequalities across racial and socioeconomic lines. These women have decreased access to family planning services, and we also know that low-income women, women of color, and immigrant women are less likely to be insured. But perhaps the most distressing is the fact that the quality of care they receive can have a powerful impact on their health and pregnancies. Women who feel alienated by the system are less likely to seek out care and less likely to stay engaged in that care. It has been said that health is relationship, yet we have a dismal understanding of the kinds of relationships that are valuable and meaningful to this particular population of women. My research is focused on understanding through interviews and observation the salient factors that shape that relationship between a vulnerable woman and her midwife in the public healthcare setting. I want to know how care happens. Can a contextualized understanding of the close bond formed between a midwife and her patient, a bond that is difficult to quantify, be the salve that is needed in communities where poor women of color are marginalized? Midwives have a long history of working with the most disenfranchised women all over the world for civilizations, and perhaps, more than new devices and technologies and spending, we need human solutions to the very human problems we face, now more than ever.